If a patient has a history of heparin-induced thrombocytopenia, that means heparin is on their allergy list and they should never be exposed to heparin, right? Actually, there is a circumstance in which we would consider re-exposing a patient with history of confirmed heparin-induced thrombocytopenia to heparin. And this comes from the 2018 ASH guidelines for management of heparin-induced thrombocytopenia, although this specific recommendation, it comes with low-level evidence and is a conditional recommendation. This specific circumstance is in a patient who's going to undergo cardiothoracic surgery where anticoagulation is needed and there is an ongoing high risk of bleeding. The main reason for this is that heparin is very quickly reversible with protamine, in contrast to the direct thrombin inhibitors, which is typically what we reach for in patients with history of HIT. Now, there are some data that have been published looking retrospectively at comparing the approach of using heparin versus using a DTI, which suggests that DTI may be more reasonable, but there has not yet been an update on the guidelines. The specific recommendation is if you have a patient with subacute or remote HIT, meaning their functional assay is now negative and their acute thrombosis has resolved, you would consider using heparin, infusional heparin, during the procedure, but post-operatively, you're going to go back to a non-heparin anticoagulant if indicated, such as fondaparinux or a direct thrombin inhibitor. This specific scenario was in fact tested on my hematology boards. Again, this is something that could change. I don't write questions for the hematology board, so I don't know if it'll show up on your boards, but it's an important concept to understand. If you practice in a high-volume cardiothoracic surgery center, I'm interested to know what your approach or your institution's approach is.